In this presentation, we'll be going over the basics of what a brain injury actually is, how it typically occurs, and what effects it can have on our patients both in the short and long term. We'll discuss the various levels of severity, the different types of head injuries, neurological implications, and lasting impact that these injuries can have on the patients that we'll serve. As you know, we plan on opening a brain injury dedicated unit at Baton Rouge Rehab, and our goal in the next several months is to ensure that our clinical and non-clinical staff is as educated and up to date on brain injury rehabilitation as possible to ensure that we are providing the best possible care to our patients. An acquired brain injury can be divided into two categories, traumatic or non-traumatic. These refer to the method in which the injury was sustained. A traumatic brain injury, or TBI, is usually caused by direct trauma to the head or skull, which can be further defined as an open injury in which the skull is broken, fractured, or penetrated, or a closed injury, which occurs when the brain is damaged inside of an intact skull, such as in a car accident or a fall with whiplash. TBIs can also occur in incidences of violence like gunshot or stab wounds, sporting injuries, combat injuries, and many other potential mechanisms of injury. Non-traumatic brain injuries, or NTBI, occur when damage to the brain is sustained without an isolated traumatic incident. The most common causes of non-traumatic brain injury include encephalitis, meningitis, brain tumors, hypoxia or anoxia, or a decrease or lack of blood flow to the brain, aneurysms, and of course, the most common cause of all non-traumatic brain injuries, strokes. When classifying a brain injury, it's also important to distinguish the type of injury a patient may have sustained. We'll discuss more on a later slide, but a concussion or mild brain injury is usually defined by only minimal or no loss of consciousness, with usually temporary deficits occurring. A contusion or hematoma usually occurs in traumatic brain injuries, like a fall or car accident, during which a specific part of the brain is bruised. A brain bleed can occur in both traumatic injuries and also non-traumatic injuries due to things like a ruptured aneurysm, a tumor, or direct trauma to the skull or brain. A coup contra coup injury is typically sustained in incidences of whiplash. This occurs when the brain is injured in two places. First, due to direct trauma of the brain hitting the inside of the skull, and then rebounding or rapidly accelerating to the other side of the skull due to quick changes in position or momentum. These injuries can lead to a wide variety of deficits due to the fact that the injury is usually sustained to multiple lobes of the brain. Finally, a DAI, or diffuse axonal injury, is usually the most severe form of brain injury, in which damage occurs in one area of the brain, but then, due to the shearing forces, is quickly spread diffusely throughout the brain, traveling along the axons. Brain injuries can also be classified as either a primary or secondary injury. For instance, if we admitted a patient who had a ground-level fall with direct impact of the head on the floor, sustaining a skull fracture and frontal lobe damage, this would be defined as a primary injury, as the damage to the brain was a direct impact of the trauma. A secondary injury, however, is defined as an injury to the brain that results as a consequence of damage elsewhere in the body or damage that evolves from the primary injury, such as in the case of diffuse axonal injuries. These can be more severe in nature due to the evolving nature of the damage. Finally, one of the most important prognostic categories for patients with brain injury to help us structure our care, set anticipated lengths of stay, and predict future outcomes is the severity of the injury. We'll discuss various levels of severity in the next few slides and also methods to assess for the severity of injury and what we expect to see in these patients. Brain injuries are typically defined as either mild, usually referred to as a concussion, moderate, or severe in nature. The severity is typically differentiated by two different characteristics: length or degree of loss of consciousness, and behavior and bedside neurological assessment using scales such as the Glasgow Coma Scale, or GCS, and the Rancho Los Amigos Scale, or RLAS. The RLAS was established for use in patients with TBI, but for the purpose of this presentation, we will define severity of all injuries, whether traumatic or non-traumatic, using this scale. In terms of length of loss of consciousness, mild brain injuries are classified by a lack of loss of consciousness or a loss of consciousness that lasts for less than 20 minutes. In moderate brain injuries, this loss of consciousness can last for up to 6 hours. Finally, in the most severe brain injuries, loss of consciousness lasts for at least 6 hours, but in some cases can occur indefinitely. When assessing severity using behavioral and bedside neurological scales, Certain scores are used as cutoffs in conjunction with length of loss of consciousness if known to help determine initial severity. We'll go into greater detail on these assessments in the following slides, but typically a mild brain injury is defined as a Glasgow Coma Scale score of 13 to 15, with 15 being the highest possible score. A person with a moderate brain injury would score a 9 to 12 on the GCS, while a person with the most severe form of brain injury would score less than 8. The Ranchos Los Amigos scale is more appropriately used to help predict future outcomes, and as we will discuss, is a constantly evolving assessment as patients' behavioral presentations can change quickly throughout the duration of their recovery. The Glasgow Coma Scale is a scale that was established for use in patients with brain injury to determine level of consciousness using 3 different response categories: eye-opening, verbal response, and motor abilities. A patient in a vegetative or coma state would score a 3 on the GCS, which is the lowest possible score. As patients emerge from these disorders of consciousness, the GCS is useful in quantifying how much consciousness a person has regained. For instance, if a patient were able to open their eyes only in response to pain, they would score a 2 in the eye-opening response category. If they were unable to speak coherently, but were able to give inappropriate responses with discernible words, they would score a 3 in the verbal response category. If this patient withdraws a limb in response to a pain stimulus, but is unable to move any limbs purposefully, they would score a 4 on the motor response scale. In total, this would give this patient a score of 9 out of 15 on the GCS. The GCS is typically seen more in triage situations at the scene of the injury or in the ICU phase of recovery as patients begin recovering consciousness. It's a helpful scale in determining initial severity of the injury, but should not be used to predict functional outcomes. As previously stated, the Rancho Los Amigos scale is less an assessment to define initial severity and more of a picture of a patient's current presentation based on their behavior. The RLAS has been extensively studied and compared to long-term outcomes of survivors of brain injury and is a useful tool in determining predicted length of stay in an inpatient setting and the potential for future recovery and need for supervision or assistance after discharge. The RALS ranges from a level 1 to a level 10, with 1 being a patient in a coma or vegetative state, and a 10 signifying almost complete recovery from brain injury. Let's discuss what each of these levels look like and what they mean for our patients. Levels 1 through 3 are defined based on patient responses as opposed to behavior because these patients have typically sustained the most severe brain injuries or are in the most acute phases of their recovery. Typically, patients in levels 1 through 3 are still in an ICU or acute care setting and may require the assistance of ventilation to breathe. A patient with a Rancho score of 1 is in a state of complete loss of consciousness without any response to external stimuli. This patient is predicted to require total assistance and 24-hour care. At a Rancho score of 2, the patient will begin demonstrating a generalized response that occurs because of a stimulus, but is usually not directed towards that stimulus. For instance, if the lights become brighter, the patient may move a limb or make incomprehensible noises. At a level 3, the patient will begin showing responses that are directly in response to and directed towards the stimulus. So when the lights suddenly become brighter, this patient may squint their eyes or attempt to roll away from the light. Any patient at level 1 through 3 will be expected to require around-the-clock care to manage all basic daily needs. On our unit, we will typically see patients with Ranchos levels between 4 and 7. Patients at these levels display a wide variety of behaviors and will require varying levels of assistance or supervision at discharge. Patients at a level 4 are characterized by confusion and typically agitated behavior. These patients usually require some degree of use of restraints to ensure both their safety and the safety of those around them. Their behavior is classified as hyperactive, bizarre, and typically non-purposeful in nature. They are usually completely unoriented and have no awareness of where they are or what has happened to them. These patients have completely absent short-term memory and little to no potential for new learning, so they are unable to appreciate the consequences of their behavior. The main goal in this typically short phase of recovery is to maintain the patient's safety and dignity as they continue to recover, establish routines that enable the patient to perform as much of their daily needs as possible, and ensure the environment is structured in a way to minimize potentially agitating stimuli. At this level, a patient would still be expected to require a significant amount of assistance with all daily tasks and 24-hour supervision at discharge. At a level 5, patients remain confused and disoriented and demonstrate inappropriate behaviors, but are no longer in a near constant state of internal agitation. These patients may demonstrate the ability to inconsistently follow some simple commands, but can become easily overwhelmed and may demonstrate inappropriate or non-purposeful responses to commands that are too complex for their understanding at this phase. They continue to demonstrate inappropriate behavior that can be characterized by verbal outbursts, which can be upsetting to family members and other patients. While these patients have some potential for short-term memory, it is still severely impaired, and these patients have trouble encoding their short-term memory into long-term memories or recalling them at a later date. While these patients are typically less agitated, they can still easily become agitated in response to unpleasant stimuli or overstimulation. At this level, patients will continue to require a significant amount of assistance with most self-care and mobility and 24 hours supervision. Patients at level 6, while still generally confused, are characterized by behavior that is becoming more appropriate in nature. These patients may only be minimally oriented, but are now able to demonstrate a more consistent ability to follow simple commands and some potentially appropriate responses to more complex commands. Memory is improving in this phase of recovery, and these patients are able to learn and improve on already well-known behaviors such as basic ADLs and mobility, but can still struggle with learning new or novel tasks. Because of the ability to retain information, these patients may benefit from a more structured behavioral management plan that involves a reward system. While these patients may have a better appreciation of themselves and their environment and be able to stick to a structured routine, they still have minimal insights into their abilities or the potential consequences for their actions, which can negatively impact their safety and the performance of daily tasks. Patients at a level 6 are usually able to perform most basic self-care with little assistance, but will require moderate assistance to successfully make it through their day, and because of the potential for injury or unsafe behavior, will still require 24-hour supervision. At level 7, patients typically begin transitioning into a less confused state. At this phase, patients are typically somewhat oriented in at least familiar situations and are able to perform most well-known tasks automatically, such as feeding, bathing, dressing, and even simple meal prep. Patients' behavior tends to become more appropriate and goal-directed in this phase if completing simple 1 to 2 step tasks. New learning is possible at level 7, so patients are able to carry over new skills and new learning from day to day, and these patients thrive in structured, routined environments. While we see a bit more awareness of deficits at this phase, patients still struggle to understand potential future consequences of action, so safety remains a large concern. Patients at level 7 can reasonably be expected to perform most self-care and mobility with very little assistance, but 24-hour supervision is still recommended. Once patients have recovered to levels 8 through 10, they're usually no longer appropriate for 24-hour hospital care and are seen for therapy on an outpatient or community basis. Patients at this level are usually becoming fairly independent with basic daily activities and now have goals to re-enter their communities, valued occupations, family roles, and gainful employment. At a Ranchis level 8, patients are now consistently oriented and have a much improved awareness of their injury and deficits. These patients are typically able to carry out basic, familiar tasks in an environment that is controlled, stable, and not providing too many distractions. The patients have an expanded capacity for organized thought and behavior, but will continue to demonstrate cognitive deficits that may require the use of external memory and scheduling devices to allow them to function in a dynamic environment. A common theme in patients at this phase of recovery, due to the increased awareness of deficits but still existing difficulties with socialization and executive functioning, is the emergence of some psychosocial issues like depression, irritability, and a poor tolerance for frustration. All of these things combined can make returning to a structured work or education environment difficult for these patients. 24-hour supervision may no longer be necessary if patients become adept at using their external cognitive devices and strategies. Patients at level 9 are beginning to regain some higher-level cognitive skills such as multitasking, executive functioning, and problem solving. These patients demonstrate an improved awareness of their deficits and potential safety concerns, but some may still benefit from compensatory strategies to manage safety concerns such as checklists, automatic timers, or even internal cueing. While these patients have improved cognitive capacity and are completing more complex tasks, they can still struggle with navigating unanticipated obstacles or issues and may need assistance problem-solving solutions. Social interaction can still be a major concern at this phase due to emotional dysregulation and the poor ability to read others' social cues. Finally, level 10 is considered to be near full recovery from the deficits resulting from a brain injury. At this level, patients should be functioning at an independent to modified independent level with all daily tasks. Patients at this level are able to detect errors or inconsistencies in their own work and take corrective action, which makes them more successful when attempting to reintegrate into a structured work or education environment. Social interaction, while still potentially limited compared to pre-injury status, has improved to the point where patients are able to interact appropriately in most social situations. The degree of impairment from a brain injury relies on several factors. The type of injury can play a large role in the severity and permanence of a brain injury. For instance, a concussion or a contusion can result in only mild temporary deficits, while a coup contre coup or diffuse axonal injury can result in lifelong, potentially devastating deficits. The area of the brain that is affected by the injury can also determine expected deficits. If an injury is focal in nature or confined to one area of the brain, we can reasonably expect a somewhat predictable set of symptoms. However, if the injury is considered diffuse or affecting multiple areas of the brain, the symptoms can be vast and unexpected. Each area of the brain is responsible for specific cognitive, motor, sensory, or processing functions. The frontal lobe, located at the front of the brain just behind the forehead, is responsible for problem solving and creative thinking, and also houses the primary motor cortex and prefrontal cortex, which enable us to plan and carry out motor functions, are responsible for most aspects of our executive functioning, or the skills required to be able to work and participate in complex environments, and house the very essence of our personalities. Damage to this area can result in not only cognitive and motor deficits, but also result in a complete change to the personality, a decreased sense of identity, and a decreased ability to control emotional responses to situations. The temporal lobes, located behind the ears in each hemisphere, are responsible for language and hearing, and are also highly involved in memory processing and storage. Damage to the temporal lobes can result in a decreased ability to understand or produce speech, a disruption in the process of sound waves reaching the auditory cortex through cranial nerves, resulting in hearing loss, and a decreased ability to learn new tasks or retain new information. Patients with temporal lobe damage can also experience deficits in concentration and attention, further limiting memory and learning potential. The parietal lobes, located on the top of the head behind the frontal cortex, are primarily responsible for our sensation and perception. The somatosensory cortex is located in the parietal lobes and is the primary part of the brain that registers physical sensations and responds to other environmental input such as touch, heat, cold, pain, and proprioception. Damage to the parietal lobes can result in numbness, tingling, and a difficulty discriminating between hot and cold temperatures, as well as some specific visual deficits, such as the inability to purposely move eyes towards a target or even being able to put together parts of a picture in order to see the entire image. Parietal lobe damage is also the most likely culprit for left neglect due to the decreased potential for perceiving input on that side of the body. The final lobes of the cerebrum are the occipital lobes, located at the very back of the brain. The occipital lobes are the primary visual centers of the brain and house the visual cortex, which is directly connected to the eyes through optic nerves. Damage to the occipital lobes, such as with a fall resulting in a hit to the back of the head, can result in a wide variety of visual deficits, such as partial blindness in various visual fields, an inability to read or recognize written words or faces, and difficulties with visual motor coordination, often limiting a patient's ability to interact independently in their environment. The cerebellum, housed in the back of the brain below the cerebrum, is responsible for coordinating, regulating, and storing all of our body movements. Damage to the cerebellum often results in difficulties with coordination, balance, fine and gross motor control, and an impaired or delayed ability to detect when the body suddenly changes positions, significantly increasing the risk for falls. Finally, the brainstem, which connects the brain to the spinal cord, is responsible for relaying all information into and out of the brain. The brainstem is also the primary center responsible for regulating our arousal, alertness, concentration, and basic biological and physiological functions. Damage directly to the brainstem can lead to significant deficits in these areas, sometimes resulting in coma or even death. Whether or not the damage to the brain is a primary or secondary condition can also play a role in the potential deficits a person may experience. As previously stated, secondary injuries can sometimes result in more complex, severe deficits due to the nature of existing injury elsewhere in the body, like an anoxic brain injury sustained during a heart attack, or due to the fact that secondary injuries can evolve hours to even days after the initial injury, resulting in more widespread involvement of more areas of the brain. We'll talk more about this in a second, but the severity of the initial injury and the severity of the injury as the patient progresses through their healing can also play a large role in the potential outcomes and also potential deficits a patient may experience. Finally, existing client factors can also play a large role in the functional and neurological implications of a brain injury. A patient with pre-existing behavioral or mental health issues may be more likely to experience the psychosocial issues that can result from a brain injury, like depression, anxiety, or difficulty tolerating frustration. In addition, if the brain injury was sustained in a multi-trauma event in which more than one area of the body was affected, these factors may lead to more deficits and more implications than the head injury alone. Let's take a look at brain injury by the numbers. Right now, it's estimated that brain injuries are occurring at a rate of 3.6 million per year in the United States alone, with the overwhelming majority of those being considered traumatic in nature. At any given moment, there are over 5 million people living with a TBI, with many of those survivors requiring long-term or even lifelong need for supervision or assistance to complete basic daily activities. We most commonly see TBIs occurring in men aged 15 to 24, but there's also a high incidence in young children under 5 and adults over 75. 75% of all brain injuries are considered to be mild in nature with minimal to no lasting deficits. However, it's estimated that 70,000 of the 3.6 million brain injuries occurring annually will result in permanent neurological damage. Unfortunately, death or persistent vegetative state occurs in a large number of the more severe brain injuries, at a rate of 30 to 40% in the worst injuries, but decreasing to 7 to 10% in injuries that are considered moderate in severity. When looking at potential long-term outcomes, patients diagnosed with mild brain injuries or concussions almost always make a full recovery and are certainly associated with the best recovery outcomes. In patients with moderate brain injuries, more than half of those patients will make a full positive recovery, with 25% experiencing a mild to moderate degree of disability. Severe disability or death is less common in this population and is usually more attributed to patients with significant comorbidities or evolving brain damage. Patients diagnosed with severe brain injuries unfortunately have the worst outlook in terms of recovery. Only around 1/4 of these patients are expected to experience a positive recovery, while most will either end up with moderate to severe disability or even death. Even patients with positive functional outcomes can deal with lifelong psychosocial limitations, with major depression being diagnosed in 25% of all survivors. This can be made worse if the patient sustained the injury traumatically, does not have a strong support system, or is unable to return to a community setting or valued occupation, such as work, school, or leisure pursuits. When attempting to measure long-term outcomes and success in patients who discharge from our inpatient rehab facility, there's 2 metrics that are often used to define the success of a patient's long-term recovery. Almost half of all survivors of traumatic brain injury were found to have been able to return to stable employment within 2 years of their injury. Less than 20% either returned to work and were unsuccessful or required a change in their job status or functions in order to maintain gainful employment. Many of these patients are going to require accommodations or changes in job responsibilities in order to be successful after a discharge from inpatient or outpatient rehabilitation. Those who are most successful in returning to work tended to be younger in age, have sustained less severe injuries, are able to get themselves to and from work, or have a strong support system to support and enable them in these endeavors. Another positive statistic is that 40 to 80% of survivors, regardless of persistent cognitive deficits, are able to return to driving in some capacity, even if that includes restrictions on their license. Survivors of brain injury in Louisiana will require a skilled evaluation by a driving rehab specialist to determine both readiness and appropriateness, which will then be signed off by a physician. For those patients who are unable to return to driving, unfortunately, we do see a higher risk of depression, poor social outcomes, less stable employment rates, and decreased engagement in the community. For more information on brain injuries for both professionals and survivors, the Brain Injury Association of America and the local chapter, the Brain Injury Association of Louisiana, provide significant amount of information on their website to help you better understand the incidences and implications of brain injury and how to best support your patients.